You know, it's interesting. We usually do the upper part first, the lower part later. So this was very refreshing to see that we did it backwards. Obviously, Bruno and I have the challenge as the two last speakers, at least on the medical aspects, before the other ones. And, you know, to appreciate that you guys stuck with the meeting for 3 days, and, you know, it's Sunday, and I know people are tired. So we're going to try to make it provocative, as Alex said. And, you know, my task is this time to focus on the upper motility, and I'm just going to show you some of the new developments that we have in the evaluation of patients with esophageal disorders. So, as you know, the esophageal disorders in children are very, very common. You know, you have the gastroesophageal reflux in one side, and then you have the problem with dysphagia and all the motility-related problems that we have. And there's a lot of new tests, and the new tests are focused on both, trying to get a better handle on what gastroesophageal reflux is from an objective point of view. And then you have tests to try to assess esophageal function, you know, particularly impedance with manometry and now high-resolution manometry. So there's no question that when you have a patient with GERD, sometimes it's obvious, right? I mean, if things are obvious, you know, if you have an arrow through your head, you just, you know, I don't think you need to do a lot of tests. But we don't have all these tests if things were so straightforward. And there's no question that even though we all know what GERD is, many patients have GERD that may be occult, that we are not sure if GERD is the right diagnosis or they don't respond to therapy. And that's where you see all this proliferation of tests that are trying to do this. When Alex and I were growing up, and I just gave away that we're very similar in age, we used to study every patient with reflux. You know, I still remember those chart recorders with pH probes that we used to spend as fellows hours measuring. And things have changed. If you talk to my fellows now, they couldn't believe that we were doing pH probes in everybody. So we've learned a lot that the testing is not necessary when you have the arrow, but clearly something needs to be done in that big population that now is the one that comes to us, because the pediatricians give the PPIs. If the kids get better, they won't have to GI. The same is in the adult. You know, so we get the patients that did not respond to the initial therapy, and that's a challenge. So what can you do for GERD? You have tests that actually measure the amount of reflux, and then you have other tests that try to correlate the presence between the reflux and the events of the reflux. So if you have cough, you want to know if reflux is causing the cough, so you have tests to do that, or apnea and sleep studies. And then the other thing is things are so complicated that sometimes you need to find indirect signs that reflux is present. If you have a kid with recurrent aspiration pneumonias, it's very hard to study them during the aspiration. So you're trying to find indirect ways to do that.